Hello, everyone, and welcome to the third session of NOW-fertility Connect. Today, we have a few questions from our patients sent to us. I'm sure this is going to raise a lot of discussion, a lot of information that is helpful for both consultants, experts in the field, and patients themselves. One of the most important questions that was sent to us is related to the events that are unfortunate events that are taking place in the Gulf area. And this is really a very important topic that we need to probably discuss as a group panelist. The question actually is talking about what are the recommendations that we advise to follow for patients who are impacted by the events in the Gulf when it comes to the treatment, managing not only their physical health, but also their emotional health. So, Luciano, being now in Dubai, probably will be good to start with you. Give us your feedback and what is your um, advice in such a situation. I know it's new to almost everybody. It's something that's not we don't see on daily basis. It's something which is new, and we need to adapt and give the best for our patients.
I believe that irrespective of the events and irrespective of where we live, prefers certainty and control over uncertainty and lack of control. And certainly the events happening in the Gulf are affecting the world, are creating lots of uncertainty, which inevitably triggers the question, what if, and how will I feel during this time? And the what if and many other questions are not going to be answered by us as clinicians, as healthcare professionals, because we have very little control over the ongoing conflict. And certainly we can put our patient's mind at rest. However, there are many uncertainties that will remain in their minds. And I think we know that many patients suffer with anxiety, with poor sleep. They become more irritable. That will lead to fatigue and a lack of control, which in turn will change their behavior and create some also some issues within the relationship, as well as may affect the trust that patients have in the healthcare professional. So I think what we can do at this point in time is actually, apart from being very transparent with patients, and perhaps in some cases advising them to focus on their mental well-being, on the general health, on body weight, on relaxation techniques. I think we can clearly say that at this point in time, the most realistic prospect of treatment will be if they accept that things may change as they go along, then yes, you can start treatment. But if the treatment itself or the potential to cancel the treatment cycle because of not being able to fly to the destination where the treatment is going to take place, or in some cases not being able to travel to the clinic even within the same city, then I think patients should be advised to postpone treatment. And not in that very critical phase, rather than sitting at home and doing nothing, they should be encouraged to spend time on themselves with the help of coaches, with the help of therapists, focusing on their diet, focusing on their mental and physical well-being. And things that I've been telling my patients is during this time, perhaps you should try to think about yourself and not to think about the treatment, because there is very little the treatment can do if you're not physically and emotionally prepared. So I think that should be the way we need to manage and inform our patients at this point in time, caused by uncertainty, caused by lack of control in the ongoing treatment cycles.
Yeah, thank you. Claire, what's your input in relation to this problem? What's your advice
Me?
to the patients? Yeah.
Yeah. So I totally agree with absolutely everything that's been said already, particularly just the control aspect and being careful of where our brains can go. Infertility, going for treatment is already a very, very stressful process. And I find getting it out of our heads and onto paper can be really useful. So just a bit of an exercise of getting a piece of paper along one side, write the things that you are in control of, like our nutrition, like our consistency with our supplements, like our relaxation schedule. And then on the other side, the things that, yes, we will worry about, but that we have absolutely no control of. So, flights, treatment being cancelled. The fact of the matter is, nobody actually wants to cancel anything. So, if something is cancelled or if plans are changed, it's for safety reasons. So if we focus on this is something I have absolutely nothing of, I have no control over, I'm going to send my energy where I can make a difference. And then that really, really helps that kind of reticular activator to go back into that, yes, I am in control mode. If I've lost some time, if something has been cancelled, that's an extra month to work on my egg quality. That's an extra month to make sure that I'm eating an anti-inflammatory diet. It's an extra month just to practice resetting that nervous system.
Yeah. Tina, what's your advice?
Yeah, I also agree on a lot of the things that have been said. So a lot of the times, when you're going through this journey, humans are hardwired for control. So when you feel like everything is out of control, your nervous system starts to go into overdrive and you find yourself feeling more and more anxious. So a very simple exercise that I teach a lot of my women that I work with is just breath work. Like a simple breath work can really help you just bring yourself back to the present. And the one that I do, there's lots of different ones that I do, but the easiest one to remember is for box breathing, 4-4-4. So just breathing in for 4, just holding for 4, and just exhaling for 4. And if you try and do that whenever you feel like things are, you're starting to feel overwhelmed, it just brings your body back to the present. And so what I always say is there's so many things that we can't control, and we think about what's going to happen next week, the next few months, next years. But I always say try and bring yourself back to today. Like, what do I need for myself? What can I do for myself today? What does my body need from me today? So just bringing yourself back to present, the breath work, all those things just help ground you and just slow you down. And not only do they do all those things, but within your body, they also signal to your nervous system that you are safe, you are here, and everything's gonna be not okay, but just that you are here, you are present, and you are safe in this very moment. So it's just something simple like a breath work can just make you feel a bit more grounded so that you're not going into overdrive. And the writing, so Claire, you talked about, the writing tools. I also do a lot of journaling, and I teach my clients a lot of journaling as well. So that's another good way to just get out anything that you're thinking about onto a piece of paper. So then you can, it's not all here. You're getting it out. You're being able to process it objectively. So again, you're bringing yourself back to the present, and giving yourself some space to breathe.
Hey, thank you. Moving forward to one of the very common problem that we face in IVF almost daily basis, and the very common question sent to us by a patient who is 37-year-old. She had 2 failed IVF cycles despite the transfer of what she reports to be good quality embryos. So her question is what she should do now. Should she continue doing IVF? Is it time to do some investigations? And what about donor eggs at this stage? Ioannis, what's your advice to such a patient?
Hello. So, at the age of 37, I believe it's not yet the point to consider moving to donor eggs. Even though the patient refers that she had 2 good quality embryos tested, the grading of the embryo is developed by the lab, and this is used generally just to make a differentiation between the embryos, does not mean necessarily that they are chromosomically normal. So what I would suggest is first to potentially identify any correctable factors that have contributed to the failures of her IVF, and then move on to the next IVF using her own eggs, because she can, for example, consider PGTA, pre-implantation genetic testing for aneuploidy. So she might discover that there are issues with her embryos being chromosomically abnormal. She can consider having an investigation of the uterus with the hysteroscopy, which is the golden standard. So evaluate the uterine cavity, check if she has chronic endometritis and inflammation inside the uterus. She can screen for other factors such as her thyroid function, vitamin D, prolactin, and according to her medical history, even assess thrombophilia or autoimmune diseases, and also assess the male factor. So not just a semen analysis, but also consider doing a DNA fragmentation, for example, on the sperm to identify if there are issues there. And after having a thorough evaluation and figure out what might have been wrong, then consider another IVF.
Ian, what is your explanation for a patient who has a normal sperm, the wife is completely normal, and yet there's no pregnancy? And especially those who have repeated IVF failures, if the sperm is good. Do you think that the sperm contributes to the quality of the embryo, and ultimately, is it a cause of repeated implantation failure if the sperm is normal?
Well, absolutely. Yes, we know that sperm integrity, especially DNA integrity, is absolutely fundamental in terms of embryo development. Usually I believe from about day three to day five is when the male fertility, male genome kind of kicks in. I think, when you're saying normal sperm parameters, well, what are we looking at? Are we only looking at a semen analysis? Because actually, if we are, then really all that tells us is concentration, so how many are there, motility, how well are they swimming, and morphology, what shape are they? Doesn't tell us anything about the genetic quality or the DNA integrity of those sperm. And I think what we quite often see is men that are told they have a normal semen analysis, so there's nothing to worry about as far as they've been told. But actually, maybe 20% of these men could have raised sperm DNA fragmentation. So, as Ionis was saying, is like, if you've got a couple where everything is perhaps it seems okay on paper, have we looked a bit deeper? And I think that is really important on the male side. And we can't just rely on a semen analysis. It's not actually a very good predictor of fertility outcomes.
Yeah. Well, I think if patients with two failed IVF cycles, if they continue doing IVF, the majority will be able to get pregnant. The problem that we face is once they do two cycles and they fail, three cycles and they fail, they just give up and they stop doing that. But if they continue, the majority, even without doing any investigation, ultimately will be able to get pregnant. So I think was a clear message to our patient.
Could I just
I
jump in as well, Tony? Just to be really clear on the difference between egg quality and embryo quality. So I think what Ionis said is really quite important to understand. That's kind of grading them in the order that is there. But as of now, there is no available test for egg quality, and it's quite well known that I think it's up to 50% of pre-12-week losses are down to chromosomal abnormalities. So I couldn't have this question asked without talking about working on egg quality, looking at the kind of toxins and plastic exposure and eating for egg quality, because it is so important and it can make a massive difference, particularly in an IVF context.
Yeah, sure. Since we are talking about egg quality, there is a question sent to us. A lady, she's 33-year-old, and she's asking, should she be worried about fertility declining at this age?
Okay. So Fertility, when we're talking about, yes, there's going to be substantially less eggs. We are born with all of the eggs that we're ever going to have, and that number is never ever going to go up. It's only ever going to go down. However, the thing that not enough people are talking about is that we only need one egg. So we have many, many millions. So in my opinion, if she wants to feel more in control, then absolutely put some interventions in place to protect the quality of her eggs. But 33, I don't think she should be concerned at all. We live in 2026. There is so many interventions, so much available to her. But for that insurance policy, perhaps make sure, yes, you're looking after your body. And if you're really worried about it, of course, look into egg freezing.
Look, Shannon,
Would you agree, Tony?
yeah, fine, good, thank you. Luciano, should a lady 33-year-old be worried about her fertility?
Well, I think the fertility in any age can be a worrying situation. And I think there are younger women with suboptimal ovarian function that should be worried, and there are older women with suboptimal ovarian function that should be worried. But clearly, the issue is as women get older, then the process of egg quality will impact on embryo development, simply because, as Ian said, the first part of embryonic development is predominantly controlled by the maternal proteins, the egg proteins and the RNA. So if women get older, they will lose the ability to perhaps get their eggs fertilized and get to the first 2 or 3 days of fertilization. The sperm becomes more an important factor after the first 2 or 3 days of fertilization. So from 4 to 8 cell stage embryo. So in my opinion, women should be worried about their fertility at any time, and should not be waiting until they have a low AMH or low antral follicle count, or until they get over 35 to say, actually, now it's time for me to be proactive. But when it comes to embryo quality, I believe and I agree with everyone that cannot just be down to egg quality. Embryo quality is a combination of egg quality and sperm quality. And the sperm is as important as the egg. And in very early stages of embryonic development, we can speculate if there is a sperm problem which is not depending on the sperm parameters, as already been said. If I see that the embryo from a cleavage stage from 6 to 8 cells to reaching the stage of blastocyst changes in terms of development, is likely to be a sperm problem. So the first part of embryonic development is predominantly driven by the maternal proteins by RNA, but post day 2, post day 3, the sperm plays an important role. And that is when we see that embryos start fragmenting, embryos get to the stage of moral and don't progress to blastocyst. That's when we see that embryos that become amoral then go back to a cellular stage. So women have to be worried about their fertility, irrespective of their age. When it comes to embryo quality, I think both eggs and sperm play a role.
Okay, thank you very much. Julia, this question is for you. Is it better to follow strict diet like low carb or plant-based diets in patients undergoing IVF treatment, or to focus on general health habits?
Sure, yeah. So, strict diets, I think the problem with strict diets is they're difficult to follow, certainly long term, and it can lead to deprivation if you're cutting out food groups. You're losing maybe the pleasure of eating because you're restricting so many things. Something like low carb, it depends on how low carb you're going, but the negative impacts can be things like you're reducing your fiber intake if you're cutting out your whole grains, for example. And we know we need fiber for supporting our gut microbiome, which is really important. For example, we need carbohydrates for energy, and we need carbohydrates for thyroid function. So if we're completely, strictly reducing this food group, that could be a problem. And then if you think about plant-based diets, I mean, if you're talking about increasing your plants, yes, that's a good thing. But if you're then thinking plant-based only, you need to be careful about what nutrients you might be missing out on. So thinking about vitamin B12, for example, which we get often from dairy products and meat, or iron, very important. Or, for example, protein. Are we getting enough protein if we're only following plant-based diets? So we need to be a little bit careful. That's not to say you can't have successful IVF if you're a vegan or vegetarian, but it can be a little bit more difficult. And I think if you are struggling to conceive, we just need to be a little bit careful that you're getting in those nutrients, maybe through supplementation that you might not be getting in otherwise. In my opinion, I think the best diet to be following is something based on the Mediterranean type way of eating, a nutrient-rich diet, and basically whatever you can do consistently and follow long term is going to be the healthiest, rather than doing some sort of cutting out for a short period of time. It's what you can do every day long term is going to be most successful.
Thank you very much. Our next question is about unexplained infertility, and Johannes, we need your help in that. Patients who are labeled as unexplained infertility, do they still have a chance to conceive naturally, or do they need to undergo some treatment? And what kind of treatment do you advise for these patients?
Okay, thank you. So, unexplained infertility means that the couple can have standard tests, normal tests. So ovulation is occurring, fallopian tubes are patent, sperm parameters are within normal range, but they cannot achieve a pregnancy. So there might be other issues that cannot be easily detected, which is issues like egg quality, sperm function, or implantation inside the uterus. Natural conception is still possible. However, it may have lower than average chances. So the ideal thing would be for the couple to undergo some investigations, so to assess the ovarian reserves, a detailed semen analysis, not just for the semen parameters such as count, motility, morphology, but also it might be helpful for DNA fragmentation, oxidative stress, assess again via a hysteroscopy the condition of the uterus, assess if ovulation is regular with ovulation P-test or progesterone level 7 days after the expected ovulation. And also the treatment depends on the age of the patient. So if the patient is younger than 35 years old, after completing a thorough evaluation, they can still try naturally for a few months. If the patient is older or if her ovarian reserves indicate that they are very low, they might benefit from moving on to IVF sooner.
Okay, so age again plays a very important role in the decision and advice to patients. Ian, there's a question about supplements for men. Is it really a hype, or do they really actually help? And what kind of supplements we are talking about here?
This is such a good question, and there are many different kind of facets to this. I think probably one of the first things to say is what's right for one person may not be right for another. And I think when you get into the world of supplements and forums and blogs, and somebody says, "Oh, I took this and then we fell pregnant 2 months later." Okay, well, that might have been right for them, but it doesn't mean it's right for you. I think there is the danger of a lot of hype and hot air around supplements. And I think patients need to be aware of that and they need to get educated. There is also the danger on the male fertility side, on the men's side, and probably true for the women as well, actually, but I don't know about the research on this, that more is not better. You know, men very much have the mentality of, okay, this is good for me, therefore, if I take 3 times as much of it, it'll be 3 times as good for me. And what we know is that is definitely not true for supplements. One of the main kind of groups of supplements that we look at for men are antioxidants. So this kind of encompasses things like vitamin C, N-acetyl-L-citrulline, glutathione, and these are particularly potent and powerful when there is oxidative stress present within the system. So the only way we're going to know that though is if we actually do a test. And you can do a very, very simple test off a semen sample that will tell you what the oxidative reduction potential or oxidative stress levels are like within the seminal fluid. Now, if oxidative stress is very high, then we know antioxidants will have a positive effect in bringing that down. But if your oxidative stress levels are normal and you take a whole load of antioxidants, then that can push you the other way, which is known as reductive stress. And this can be just as bad as oxidative stress because it can actually limit some of the sperm function. So it is with antioxidants really, really important that we find out what state a man is in. Then, if we look at other things like maybe folic acid, vitamin C, vitamin E, zinc, selenium, all of these are often also within antioxidant supplements, and a lot of these are chosen because they are very good at supporting sperm health and function. We know the impact that zinc has, we know the impact selenium has. So, what I tend to say is if you've not had an oxidative stress test, but you feel like you've got nutritional gaps or deficiencies, you don't like vegetables, you don't like fruit, or you're a shift worker, or you're having, you're skipping meals, or you're grabbing ready meals. If you're a bit concerned that there is a gap in your nutritional profile, then maybe taking an all-in-one male fertility supplement would not be a bad idea, but keep it balanced and sensible. Don't overdo it. Really, supplements are there to supplement. They're not there to be a fix or a cure. The first line of attack really ought to be lifestyle and diet and making sure you're eating a good Mediterranean style diet. And I'm sure, Julia's already unmuted. I'm sure she's got plenty to add to this. Go for it, Julia.
No, I was just going to say, I think you mentioned it anyway, but vitamin D is a really classic one because we know it's from the research it's really important for male fertility. And I see a lot of men where, we test the vitamin D and it's really, really low, quite surprisingly so. And if the NHS does actually say everyone should be taking a vitamin D supplement, particularly during winter and autumn, but the dosage they recommend is very, very low. And it's nowhere near enough to get you up to an optimal level. So I completely agree about the oxidative stress testing, but I think a simple, which can cost about £40, vitamin D test is really important. And quite often the multivitamins don't even have enough vitamin D, sometimes what people need just to get you up to that optimal level. So definitely worth testing a few things.
Yeah, and this also applies, vitamin D also applies for women. Studies have shown that women who have low vitamin D undergoing IVF, they tend to have a lower pregnancy rate than those who have normal vitamin D levels. We mentioned a few times DNA fragmentation during this session. So is it really an issue, and how much does it really play a role in preventing pregnancy and leading to IVF failure, Ian?
Well, I think we've already covered a lot of this, haven't we, really? That a semen analysis tells you one thing, a DNA fragmentation tells you a very different thing. I think what we need to understand is, okay, well, what are we looking at when we do a DNA fragmentation test? We're looking at what's going on to the DNA in the head of the sperm. That DNA is the blueprint. It's the blueprint for a healthy embryo. That DNA blueprint matches up with the DNA blueprint that the woman provides via the egg. And if DNA fragmentation is present and the egg can't make sense of that blueprint, then that egg is not going to fertilize or the embryo is not going to develop very well. And so we know there is a strong amount of evidence now that raised sperm DNA fragmentation will impact fertilization rates, it will impact embryo development, it impacts live birth outcomes, it leads to recurrent miscarriage. It's another one of those subjects that perhaps hype is probably too strong a word, but there is maybe some conflicting information out there that patients get about the validity of the test or what you do with the information. I think what's important is if you do the test and you find that you've got high DNA fragmentation, is that you take yourself to see, the man goes to see a male fertility specialist to try and understand what is causing that DNA fragmentation, because there are many different causes, and the vast majority of those causes are entirely reversible, meaning that you can improve sperm DNA fragmentation in most cases, not always, but in a lot of cases. So yes, it definitely plays a role, and yes, it needs to be investigated fully so that you give yourself the best possible chance.
So do you do it routine for all patients with infertility?
So that's a good question. So for us at Testing, we have a lab in London and we provide these services, but we provide them for clinics and clinicians. So we're not directing, we're not providing them directly to patients ourselves. It comes through clinics and clinicians. So I've forgotten the question. It just went out of my head.
So you recommend it to be done routinely to all
That's it.
patients?
So no, and this is the thing. It's like, if you're just starting to try and conceive and it's been 6 months and you're a bit curious about your fertility, going and spending £800 or £1,000 on various different tests probably isn't the right course of action. We would say if it's early days, then a semen analysis is a good starting point. If that reflects any problems, then you might want to go and dig a little bit deeper and find out what's going on. But if you're 12 months, 18 months down the line, or maybe you're a slightly older couple or a slightly older man, and things aren't going to plan and time is ticking along, and conception hasn't happened despite months of unprotected sex, then yes, we would recommend digging a bit deeper. But certainly if we look at kind of a potential bullet point list of when to consider advanced testing for men, it would be failure to conceive within 18 to 24 months, recurrent miscarriage or loss, recurrent IVF failures, or, as we discussed earlier, unexplained infertility. If you kind of tick any of those boxes, then it's time to dig a bit deeper on the man, and then we would want to run some of these further tests. Or, sorry, I will add, if there's anything in the history in terms of risk factors, and that might be previous STIs, undescended testicles, maybe history of a varicocele or suspected varicocele, then we need to be looking a bit deeper.
You mentioned that in most patients you'll be able to manage a high DNA fragmentation. So what kind of treatment you advise patients?
And this very much depends, I have to say. And this is where we get into the technicalities of single and double strand breaks, perhaps. But if we've got high DNA fragmentation, and maybe it's total DNA fragmentation, and we haven't distinguished which type of fragmentation it is, then everything that we've talked about on this session and previous sessions around lifestyle and diet is always absolutely essential. So that Mediterranean style diet, good hydration, limiting alcohol, caffeine, heat exposure, tight fitting underwear, mobile phones in the pocket, all of this helps with sperm health and DNA integrity. But we've also then got to look at, are there underlying causes like a varicocele or maybe a low-lying infection? So again, this is where further investigations by a male fertility expert may be needed. Then once we've ticked off all of those elements, it may be, if it hasn't improved, it may be there could be what's known as double strand breakage going on, and that tends to be more of a testicular function and potentially a genetic factor going on. But we've got to do all of those other elements first, because we know oxidative stress is a big driver for sperm DNA fragmentation.
Tony, sorry, I may want to add something if I can, Ian. I think the problem with sperm DNA fragmentation test and what patients perhaps sometimes don't see is that has taken a huge commercial role in many clinical settings. So there are at least 4, maybe even more, sperm DNA fragmentation tests, from the tunnel to the SCSA to the Halo to the Comet, and every test is different.
Mm-hmm.
And every test should be interpreted different. And each clinic or different clinics may use different tests, thinking actually they give the same information, but the tests don't give the same information. And as a result of that, patients may be labeled as having, for instance, sperm DNA fragmentation, high sperm DNA fragmentation in the sperm analysis, when in fact they may have a completely different answer from the test actually was initially done. So we we often deal with patients that come to clinic and say, I've had a sperm DNA fragmentation test. May have been just a tunnel assay. That is not the same as the comment. Doesn't give me the same information.
Yeah, absolutely. And this is a really important point about the different types of assays or tests, and that they do measure different things, and the process for that test is slightly different. I think, what's important is if a man has had one type of a test and he needs to repeat a test to check whether an intervention has worked or not, then it should be the same test. So if he's had an SCSA and he needs to have a repeat test, have another SCSA, because you are then comparing like for like. Funnily enough, we've just put an article on the testing website about the different types of tests and their strengths and to some degree their weaknesses. Some are stronger than others in terms of reproducibility, reliability, and robustness. Some have inter-user kind of variability, much as a semen analysis has huge variability depending on the user. I think regardless of which test you've had, and actually I'll come back to that. No, in fact, no, let's go there now. I think what's important is it's got to be clinician's choice. So I think what's important is the clinician needs to make a choice of which DNA fragmentation test they would like to use based on their knowledge, experience, research, and what that test is hoping to tell them. And that will be based on the patient history and clinician's kind of history as well. But I think what's really important is that clinical oversight. I think patients potentially going off, there are postal services for sperm DNA fragmentation testing available, and that is potentially dangerous if there's no clinical oversight. So I think it's got to be go to a clinician, go to a clinic, wherever it is, that they can justify why they want to do that test, what test they want to do, and then what they're going to do with that. And I think regardless of what test it is, whether it's a COMET or an SCSA, if the result comes back high, that man needs to see a male fertility expert to understand why that DNA fragmentation may be high. In some regards, then it doesn't matter whether it's measured by a COMET or or an SCSA. If it's high, it's probably an indication that there is something else going on that needs to be investigated.
I agree, but the problem is, as you say, that they do a test, say SCSA, and that comes back as high. Then they go and have a halo test, which comes back as normal. And they think, actually, no, I don't have a sperm DNA fragmentation problem.
And this is why, again, repeat with the same test. But you could say, exactly the same around semen analysis. A guy can do a semen analysis and it can be below the percentiles for WHO standards, and they can do another one 2 weeks later at the same lab and get a completely different result as well. So DNA fragmentation will also vary. Abstinence periods will be a factor, whether he's had an infection or a fever. But the point is, if there's any cause for concern from that result, further investigations, maybe an infection screen, maybe an ultrasound, maybe a hormone profile, need to be considered. If they all come back clear, then okay, we've got a green light to continue.
Thank you very much. Our last question for this session is quite interesting and challenging at the same time. And the question is to everybody here. How you as consultants, as coaches, nutritionists, how do you work together? How do you coordinate your work to give the best outcome for the patient, to give a holistic approach to the patient? How do you do it? Do you coordinate with each other? And how do you refer patients to each other? Julia, Claire, Tina, Luciano, Johan?
Yeah, happy to answer or to chip in. So I do, where I can, I will always work alongside other consultants or other people that are involved in their medical care. I mean, for example, classic example talking about male fertility is, what I can do is help with the diet and lifestyle if there is a male fertility issue, but what I can't do is a physical examination or check for any structural issues or anything like that. So if I believe from a semen analysis or from a DNA fragmentation result that there could be something else going on, then I will always refer to a urologist for them to see the client and to to do their tests and investigations. I think that's really important. And they can offer different testing from things that I can do within my clinic. And then I also work alongside other holistic practitioners. So I work with personal trainers, acupuncturists, reflexologists, counsellors, because I think where appropriate, other services, if we can work together, we can get the best outcome for patients. So it's assessing what they need, and if I feel they need to see an acupuncturist or something like that, I think that can improve their results, and that's obviously the ultimate gain for them to get the best results they can.
Tina?
Yeah, I mean, similar to what Julia said, it's very, so I have to be honest, I'm in Asia, right? So it's quite, everything's quite disjointed here. And I've been working really hard with clinics that I partner with to bring in a more holistic approach where we are working together and not in silos. So at the moment, everyone's working a bit in silos. So I'm trying to do my best to, again, bring in that holistic approach where we are recommending, okay, have you considered seeing an acupuncturist? From a medical perspective, getting the clinics to encourage patients to see various specialists. Like when I was going through my journey, I had to see a rheumatologist, endocrinologist, my husband had to see a urologist, but it was very disjointed. So we are trying our best here to try and bring it all together a bit more. So we are signposting patients to go and see various people within the medical field, but also that holistic approach to see, okay, do I need to see a therapist, a counselor, a coach? And what these different people can offer and bring to the table. So I think we are getting there. There is still a long way to go, but we are trying to bridge everything together for the patient to try and make it as easy as possible, a seamless experience, and also one where they feel like they're supported at every stage of that journey, because there's so many different specialists that you see when you're on this journey, and it can feel quite daunting and scary. And so trying to bridge it together and offer that support from end to end is really, really important. It's something that I'm definitely working on with a lot of the clinics here.
Yeah. What about you, Claire? How difficult is it for you to work with consultants, coordinate with them, nutritionists, and all other coaches?
So, first thing I would say is kudos to NOW-fertility for creating networks like what we're doing right now and actually showing to end users that we do talk to each other and we are very much interested in what each other has to say. But in terms of coordinating it, it always needs to be the client at the center of it. So the patient is the person who we are all working on. And I always think it's very important that they understand why I or anyone else is asking them to have a procedure or make any changes. So everything needs to be via the client because it's about the client. And I'm also really big on transparency with them as well. So all of my notes, all of my kind of tracking, everything, everything that I work on with my clients is available to them on demand so that they can share it with any, doctor or consultant that they need to. And then obviously Julia touched on personal trainers as well. It's not uncommon at all. I actually prefer to design all of my clients' own workouts, but I'm a bit of a control freak. So if they want to stay working with a face-to-face personal trainer, I'm very happy to get on the phone to them and tell them exactly what I do and don't want happening. So anyone that's happy to collaborate, I'm there. As Julia says, it's about the client. It's all very clear what the end goal is. We've all essentially got the same end goal for each client.
Yeah, that's true. Johannes, do you believe in this holistic approach? And do you send your male infertility patients to a male infertility specialist, or you take care of them yourself as an IVF specialist?
No. General advices I can give myself for sure, but to have a thorough examination, they always get referred to specialists. So teamwork is always better, coordinated, not parallel. A fertility consultant can lead the plan, so define the diagnosis and the treatment strategy. The nutritionist needs to align the diet of the patient, correct any deficiencies. The fertility coach or counselor has to manage the patient's stress, make decision making, support emotionally during the treatment. So everything works better if a team works good together.
Correct. Last word to you, Ian.
Oh, goodness me. I kind of think it's already said, and really fantastic to hear Iona say exactly that, actually I think where we have an integrated approach where people are talking to each other and cross-referring, it creates the best results. But it also creates, most importantly, like Claire says, it creates the best patient experience. And I certainly know we've had a few people on our podcast, people we've worked with, where a gynecologist and a urologist are in effect running a joint clinic. So the man is getting a precise kind of treatment pathway and assessment alongside and at the same time as the woman, so that actually they are both fully optimized, ready to go, whether that's for IVF or trying to conceive naturally. So it's not this case of, two years down the line and maybe two failed IVFs that were like, oh, let's go back and look at the man. I think, this whole holistic approach and joint couple approach makes a huge difference. And I think any clinic or consultant that works in that way will only get very positive feedback from patients because they will feel properly cared for and listened to as a couple.
Okay, thank you. Thank you very much, everybody. This has been quite informative session. Thank you all. Hope to see you again next month with a new experience. Thank you very much.